If there are no other questions right now, we're going to go to Dr. Bangal's presentation, which will maybe give you a bit of an idea of the types of activities that they undertook. And please go ahead and keep putting questions into the chat. And I'm happy to stick around as long as folks need, as long as you can stay at the end if there's a lot of questions. And Dr. Bangal hopefully can stay as well. Apologies for the little hiccups. Oh, sorry, go ahead, Dr. Bangal. Did you want to say something before I start your presentation recording?
Yeah, I will just do a brief introduction and then we can proceed with our video. Hello, everyone. Good morning, good afternoon, good evening with all your different time zones. I'm Dr. Bangal. I'm obstetrician by profession. I'm a full-time teacher working in one university hospital, which is a huge hospital with 1,300 beds. All my personal details are there about the hospital in our video. Since the monsoon has just begun in India and the internet connectivity can be an issue, so we thought that we will record the video and then show it. But I am very much here and the internet is quite working now. But yesterday only we recorded this, and I'm very much here to, if there are any questions, to. It was a great experience for last 3 years working with the ICI, and many good changes have happened in my maternity services, maternity ward, physical infrastructure, quality of care, and the feedback received from the women or the mothers who have delivered there. So we are very happy about having this association with ICI, and all the details. I'm quite sure that you will get all the information about my facility through my. There are many pictures. Pictures will they will speak on themselves. So I request Michelle to run through the video. Yeah. Good afternoon, everyone. I am Dr. Vidyadhar Bangal from Pravara Institute of Medical Sciences. I'm very happy to be here with you all in this ICI webinar, in which I'm going to speak on implementation of 12 steps to safe and respectful mother, baby, family, maternity care, which we have implemented since last 3 years. At the outset, I thank ICI, Andre, Michelle, for giving me this opportunity to share our experiences of implementing 12 steps of ICI at our hospital. I bring greetings from Pravara Institute of Medical Sciences. I'm working here since last 35 years. And this particular hospital is a tertiary care hospital having 1,300 beds, indoor beds, of which 120 beds are allocated to maternity ward. This particular hospital is no less than a home away from home for these beneficiaries who are rural peasants working in the fields, agriculture laborers. And for them, this type of facility is really a boon as far as health matters are concerned. In this hospital, approximately 11,000 deliveries take place every year. And if you see in this graph, it is increasing day by day because of the trust this hospital has got with the community. Our C-section rate is around 35% in last 5 to 10 years. We monitor all the labor care quality indices on regular basis, and that help us in trying to find out any deficiencies in care are there. Labor room obstetric protocols are set, and accordingly, these protocols are being followed by the team. This particular facility is Government of India approved, and it has been certified for best quality care being provided here. We do have collaboration with White Ribbon Alliance, and I'm happy to show that phase 1 ICI certification has already happened in July 2021. That is almost 3 years back. This is my nursing team at Pravara Rural Hospital. Although the beds are 120 for maternity, we have more than 150% occupancy, meaning by I need to take help of other wards for keeping my mothers after the delivery or before the delivery. But we follow that all the respectful maternity care is provided. There is no sort of what we call it as a two women or two mothers on single bed. We have sufficient beds in the hospital, and that's why this hospital is being preferred by the community. We have core values. We follow compassion, empathy, respect, care, and support. We do provide privacy, confidentiality, autonomy to the women who are coming, and we do not discriminate any woman who is coming to our facility for healthcare services. Although I am going to show step by step how we have started and how we have implemented our ICI 12 steps. But I think that you just have an opinion about all the steps and overall quality of care being provided by this hospital. I am very happy to say that in last 3 years, a lot of improvements have taken place since we came to know a systematic way of improving the quality of care through ICI 12 steps. Our labor unit starts with obstetric care, which is a decent facility, runs 24 hours a day, and all our medical officers, resident doctors are attending this obstetric triage. Ours is a tertiary care hospital with postgraduate students, 12 admissions per year. So I have sufficient manpower as far as resident doctors are concerned. In my hospital, in the ward, I have 130 nursing staff available for maternity care, of which 35 nurses are working round the clock in rotation in the labor room. So this is the obstetric triage which is functioning, and the doctors are attending them, and we do follow triaging codes, color codes, while these women are being attended in the triage. This is a dignified and respectful care being provided in the labor room. This is the indoor labor in a picture of my labor room. All the beds, I have 14 beds, labor beds available, and all the beds are been segregated. So all the confidentiality and privacy of all women is being maintained. As far as antenatal ward is concerned, these are our antenatal wards, spacious with adequate space in between. All women are given clean clothes on day-to-day basis. This was a COVID time picture with woman with the mask, and cleanliness is given utmost importance. This is the dignified and respectful care in the form of a waiting area of my labor room, wherein all the important information is put on the boards and women are sitting there waiting. There is a communication system from the labor room to these women. This is just outside the labor room. We have started a pharmacy just in this section only, so that the relatives have not to go anywhere else to get the medicines. They are immediately available. This is a charitable hospital. The charges are almost zero. Only the medicines are being brought by the relatives, and otherwise no hospital charges are asked at the end of the delivery or maybe at the end of C-section. In the lower picture, you find it's a spacious labor room corridor with women sitting in the upright position with during their labor care. Safety of the woman during internal transfers from one ward to another, from a ward to operation theatre, whenever they are being shifted, their safety is really given a lot of importance. Stretchers are with safety railings and shifting women on wheelchair by the hospital staff that is being looked after. This is another thing we encourage women after operative delivery to be ambulant as early as possible with the walker support, chairs for rest during ambulation, which I have shown in the earlier picture. And I strongly believe that respectful maternity care begins in antenatal period. This is our medical superintendent of the hospital and the nursing superintendent. They very often come to antenatal OPD. We celebrate various days, and these women who have come for their maternity care or maybe during antenatal care, they are being greeted on various occasions, and that's how a good rapport is built from the antenatal period itself. I have at least 150 to 200 pregnant women coming for antenatal care on day-to-day basis. So it's a huge number, and we are happy to serve these women from the antenatal period. This is another picture of organization culture of respectful maternity care, in which the central person is our chancellor of the university and director of the administration. They are coming to the ward and celebrating certain days. Pediatric HOD is seen on another picture. So this is how, from top to bottom, from the chancellor, vice chancellor, dean of the hospital, they are regularly visiting the maternity care and trying to find out what is the quality of care and what is the clientele satisfaction, how the services can be improved. That is being seen. This is maybe a last year's celebration of our Women's Day, and these days are very often celebrated. And that is another opportunity to educate the women, take their feedback, and try to improve the services. Suggestion box is just kept outside the labor room, which is opened every alternate day, and we do take care of the suggestions received from the patients. Feedback form is also there from the women. In addition to our ICI questionnaire, we also have another hospital service feedback, which is a general feedback, whereas we are implementing our ICI questionnaire, both spouse as well as the pregnant mother, and almost to my knowledge, by this date, more than 2,000 questionnaires have been implemented or used to find out the quality of care. We have displayed the patient charter, roles and responsibilities outside the hospital and also outside the labor room. They are in the local language so that women can understand what are their responsibilities, what are their rights, and accordingly, they are receiving treatment at our hospital. Coming to ICI step 3, 4, and 5. Let me tell you, when we started with this ICI program, it was 12 steps, and we thought that where we should begin and what all steps we can take them later, because we are already doing good as far as those steps were concerned. Out of 12 steps, 5 steps we were very happy. I am heading the department, and I was very happy about the 5 steps. It was step number 2, step number 3, step number 6, 9, and 12. So these 5 steps we thought we are doing quite well. And of course, other steps needed real intervention or improvement. Accordingly, now step 3, 4, and 5, we started with the birth preparedness through prenatal classes by relieving anxiety, fear, apprehension related to birthing process. These are all rural women having a lot of anxiety, and this is such a big hospital that they are not oriented to the hospital premises, hospital staff, hospital facilities, because they stay in rural areas, small villages. So we have started since last 2 years orientation to various techniques and the non-pharmacological methods of pain relief in the labor room, in the antenatal period. And these are nursing staff who are showing the various methods of non-pharmacological tools for pain relief during labor. These classes are held regularly in the antenatal period. Birthing ball, peanut ball training is taught. We are happy and lucky to have physiotherapy, College of Physiotherapy, College of Nursing attached to this university. So I have incorporated their services and also taken the help of them. Those postgraduate students and faculty come to our antenatal OPD and give all these conduct educational sessions in the antenatal OPD. Birth companion was not being fully implemented maybe 3 years back, but with ICI 12 steps, and one of the steps is totally devoted to having a birth companion of choice of a pregnant woman. Now we have 100% deliveries being conducted in the presence of birth companion. We have given them iCards so that we identify that this is a birth companion or labor companion, and accordingly she stays not only during first stage but also in the second stage. Baby is being handed over to her from first stage. She is even going to the newborn baby corner so that there are no problems of even baby being exchanged and all. Once or twice, maybe 5 years back, we did face that difficult problem. But now with the implementation of labor companion, we are not facing any such problem. And women are also very happy with this sort of provision of a labor companion. They are comfortable with their own family member around. This is another training of a birthing ball. And if you see in the slide, we also started a program on mindful motherhood, in which the women are given psychological support, those who are found to be depressed or likely to be depressed during or after pregnancy. So this is another session we have started, orientation to birthing ball. These are the different photographs. And we have also incorporated yoga. We all know that yoga has a definite role to play in relieving anxiety, being calm, stay calm during pregnancy. It reduces the pain during pregnancy, also the pain during labor. So the orientation class of yoga is being regularly held in our antenatal period. As I already said, this is a program of mindful motherhood being implemented in the antenatal period. This is our counselor, our medical officer, postgraduate students, and the nursing women. We conduct it in a small group, and the women are quite happy with this additional service. An educational session on mindful motherhood. These are some of the pictures. This is booklet on yoga during pregnancy that we have started, and that is really been very much useful in women for yoga, knowing what is the yoga sequence and how it is. It is in a local language. So this all yoga sequence is being taught to the women, and they also follow it at their place, at their home. Yoga for physical and mental health. This is another session being held in the antenatal OPD. Birth preparedness helps in birth preparedness also. Orientation to delivery room during pregnancy as a part of birth preparedness. Many times what happens that these women from rural area, they directly enter, maybe out of 100 women, 30% women are still unregistered at our hospital. They directly come to labor room. And seeing all this picture in the labor room, they get confused. There is a lot of apprehension. So now recently, last 4 or 5 months, we have started. We are taking these women, pregnant women from antenatal OPD to the labor room. And these nursing staff are orienting them to all the facilities available, not only the facilities, but the staff available there. And they are quite happy with, and they are going oriented towards these facilities. So this is one of the picture. This is the orientation of squat bar, so that subsequently when we ask their choice about, so they know what we are asking about. So this is showing the squat bar and how it is to be used. This is a birthing chair that we have in our labor room. And lots of, I will show you the statistics, a lot of birthing chair deliveries are happening. We actually allow them to sit on the labor table, which are specifically meant for demonstration purpose. A birthing chair, they actually sit and see. This is the rebozo being used or being shown. And we also have hydro labor facilities since last 6 to 8 months. And I'm happy to say that 110 hydro labors have been conducted in our hospital since last 6 to 8 months. In my labor room, approximately 1,000 deliveries are being conducted every month. That's how it goes to almost 11,000 or 12,000 per year. So this is a hydro labor, which was my personal dream project, which I inaugurated at the hands of one of the international midwife who is working in India, and another officer who is in charge of skill-based training in India. So this was just a birthing unit, and this is the inside of our birthing unit. This hydro labor facility, and more than 100 women have already delivered in the last 6 months. Orientation to delivery term. Now we do ask them, show them the information regarding various birthing positions using a chart. These are my medical officer and resident doctors. Each and every pregnant woman is shown various birthing positions. They have been taught, pros and cons have been told, and accordingly they choose. We write down their choice on the antenatal card, and when they come back, we again tell them that this was your choice. If they want to again choose another, they are free to choose it, but the orientation is already done about various birthing positions through various sessions conducted by doctors and social workers. We also encourage male companion since last 2 years, and these are the male companions present in the labor room, observation room, and they are happy with these additional services. There is active engagement of male partner during the immediate postnatal period. Not only that, but we are permitting umbilical cord cutting by male partner actually in the labor room, with all the privacy and confidentiality of all other women being taken care of. These are alternate birthing positions which are actually being practiced at my place. All the different positions are being practiced since last 2 years. More than 6,000 deliveries have been conducted in 2 years with alternate birthing, not supine, non-supine position. They have been conducted. There is a midwife conducting delivery of a woman in reclining position. There is a midwife conducting delivery while woman is in a sideline position. Midwife conducting delivery while woman is hands-on, hand and knee, that is all four position. And we are also using pharmacological and non-pharmacological methods of pain relief. We encourage them to take plenty of oral fluids. Previously, this particular thing was not being done for the fear that if she needs to go for C-section, so her stomach will not be empty. But with the new concepts, we are encouraging them to take fluid. We are using massage and hot fomentation for pain relief. This is being provided by the labor companion. There is a wide corridor in the labor room area where the women are freely about moving. Rebozo use while using birthing ball. Counter pressure and touch technique for pain relief in labor. Massage and hot fomentation, which I have already shown. And we also started with the aromatherapy unit, especially in the hydro labor facility. In addition to this, for pain relief or for distraction technique, we have devotional music serving purpose of labor analgesia with the speakers in the corners, and devotional music is run. Women also practice focus and distraction technique, listening to music, using earphone. Spiritual religious reading. I have started with the labor room library, having all these small books and booklets. They are using it while they are in the first stage, not in the active stage of labor. Hydrotherapy for pain relief. They did not deliver in there, but if they want to have pain relief, they are also provided option of hydrotherapy. In addition to all these techniques, I do have transcutaneous electrical nerve stimulation. That's what we call it as TENS, as an additional facility for women who opt for it. In addition, last 2 months, I have started with Entonox for pain relief. It's all their choice. We give them all the options, whatever they want, whether it's a pharmacological, non-pharmacological, but we encourage them to use non-pharmacological first, and then if not, then pharmacological measures are all available. Epidural for labor analgesia is also available with the help of Department of Anesthesiology, and alternate birthing positions being practiced, which I have just told you. These are some of the pictures of those alternate. Midwife conducting delivery with woman in squatting position. This is another using the use of a squat bar. Lithotomy position for the high-risk pregnant women or those who opt for that position. Chair delivery in the second stage of labor, third stage of labor. Experience sharing. This is another important thing. At the end of the delivery and before they go home, we conduct small session and ask for their experience about their labor. These are the multigravidas who had previous delivery in a lithotomy position or a lying down position. And now all of these women have delivered in a non-supine or vertical position. And we asked them their experience. What did they feel? Was there any difference? And we got a very positive response from these women regarding shortening of the second stage of labor, less pain, and their comfort level was much better in an upright position as compared to the lying down position when they are primigravidas. We do express our gratitude for sharing some feedback. ICI project coordination meetings are being held on very regular basis. We have 15 members in the team, of which 2 are obstetrician, 2 are pediatrician. We have 6 nursing staff, nursing superintendent, 2 form community members, and social worker, counselor, and psychologist. This is the big team, and we are regularly conducting. We do have a direct social support group for these women, and they are giving their feedback from the community. How do the women assess or judge the quality of services provided by our hospital? Coming to ICI step 6, 7, and 8, we have monitoring of labor room quality indices, as I said, inductions percentage, augmentation percentage, C-section, AMTSL, episiotomy rate. I don't hesitate to say that 4 years back, my episiotomy rate was 88%. With strict monitoring and guidelines and strict protocol following, now it has dropped down to 44%. So 50% reduction in the episiotomy rate, and I give major credit to implementation of this ICI, orientation to the staff regarding doing only judicious following only judicious practices, evidence-based practices into the labor room. Labor room quality improvement projects have been implemented. As I said, episiotomy procedure, delayed cord clamping, baby breast crawl, AMTSL, and use of Robsons for C-section. So these Robsons have been put at 3-4 places in the labor room. All women deserve respectful maternity care. This has been the main area of focus. All these women are being provided free food and pantry facility to all the mothers, washroom facility, poster display of handwriting, hand hygiene, waste segregation of buckets, and all the safe drinking water and hand wash facility. Coming to step number 9, 10, and 11. As far as this step is concerned, we were very, since it's a tertiary care hospital, it's all well equipped with the emergency obstetric care, and all the team members are geared up to provide these all common emergencies like postpartum hemorrhage, eclampsia, sepsis, inversion of uterus, retained placenta, hemorrhagic shock. They are being taken care of very well because it's a common emergency and everybody is oriented. There is an alarm bell whenever there is something going wrong in the labor room. Alarm is put, and all the care, the people in the area around the wards, they rush to the labor room, especially our staff members, residents, in order to help us. There is a newborn baby corner in the labor room, which is, and of course, other abnormal presentations. It is said that breech delivery is become extinct, vaginal breech delivery. We need to really, in order to reduce the C-section rate, at many places, all breeches are being delivered by C-section, which is not the case at my place. The residents and the faculty member are practicing vaginal breech delivery. Educators. WHO labor care guide provided and maybe suggested by WHO. It is being used at my place. That's how all the 7 sections of the labor care guide are being filled by the resident doctors. These are some of the sessions of labor care guide to the and midwife supporting early initiation of breastfeeding. We always keep mother and baby together. That is since many years. That's why I said that some of the steps we really did not want to really work on that. And even after the delivery being conducted on the labor delivery chair, immediately breastfeeding is started. So we are all here for taking better and better care of our mothers, as we all understand and agree that every mother counts and every baby counts. We all are committed to work together for evidence-based, safe, and rich birthing experience. I thank you all for your patient hearing. I'm there for the session in case of any question answer session. I once again thank ICI, Andre, and Michelle for giving me this opportunity to share my experiences of ICI implementation 12 steps at my facility. Thank you very much.
Thank you, Dr. Bangal. I just want to say, for the question, Joseph Pataki, nous avons une présentation en français qui sont enregistrées. Je peux partager un lien après cette réunion. C'est pas exactement le même, mais nous avons une présentation de l'hôpital de Tunisie. Je pense que c'est disponible. Sorry, Dr. Bengal. I don't know why.
No problem.
I'm not seeing the translation captions. Oh no, okay. Now I am. When I was sharing, I couldn't see it. Maybe it couldn't caption the video. So I'm sorry about that. I think now, let me see. It might be possible to do the captions. Are there questions for Dr. Bangal? I see a lot of comments, but if anyone wants to unmute to congratulate Dr. Bengal, or I'll read out your comments.
Amazing work.
Thank you very much.
Excellent job.
Thank you very much.
That's very impressive.
We need to believe that, yes, there is a scope for improvement. And once we once we decide that yes, these are the areas they must be improved, then I think uh, we will be able to definitely improve those areas of our care. So that's what I'm doing. And every day, every month, every year, things are improving. And that is how it is. The number of women opting for care and delivery is going up, and we are very happy about it.
Okay, and I just want to respond to the questions about the slides and the recording. So we have been sharing the recordings by email, and I know everyone registered with their email, so we will send out an email with a link to the recording and also to the presentations. So if you don't see it in the next couple days, check your spam. Hopefully it will come through, or you can follow up with an email to me, and I'll put my email in the chat just in case you have trouble if you don't see that coming through. Does anyone, oh goodness, people are still coming in. Does anyone have questions about maybe any of the sort of specific challenges or things that Dr. Bengal had to do? Oh, here we go. Sophie is reliable for giving us a question. Sophie from Canada is asking if there's policy about sort of for the cleaning of the tubs.
Yeah. There are clear-cut guidelines about cleaning of the tub, and maybe I think we have a tub delivery once in 2-3 days, so there is sufficient time for taking care of the tub. And I myself was not knowing about it, but then I contacted one of the international midwife, and she sent me a document about how there are guidelines. Sort of, this is a guideline that says guidelines for use of water during labor and birth. It is by NHS, Milton Keynes University Hospital, NHS Foundation Trust. So there are guidelines about this, how to take care of the tub, and those guidelines we are following. All the chemicals, what are to be used, how to be used, because the tub has to be. At present, we are taking only low risk women, and there are certain contraindications which women should not be taken into the tub. So those contraindications for tub delivery that we are strictly following, especially those women with leaking membranes and having some acute infection, having febrile illness, those conditions we are avoiding. We are not taking any high risk pregnancy into the tub. And as far as the tub is concerned, it is cleaned with plain water, and then all the germicides are being used to clean the tub, and accordingly we take care of the tub. It's only just 8 months back we have started, but I'm happy that more than 110 deliveries we have conducted, and I have just yesterday tried to compile the data, and it shows that the important thing is there is no birth asphyxia, there is no post third stage complication. There was no occasion where we had to take the woman out in an emergency, because the case selection was good. Since it's our initial practice, we are taking only multi-gravid women, not the primary gravid woman, into the tub. Low risk women having a birth weight, expected birth weight less than 3 kilograms, 3,000 grams. So these are some of the inclusion criteria we have decided, and with this we are quite happy with the results.
Just wanted to check. There's a question from Kim Chi Luong, asking about if there's been any impact on the cesarean section rate since working with ICI. I don't know necessarily, Dr. Bengal, if that was a target or a goal of yours at any point, or if that might be a future one.
since this is a tertiary care hospital, lot many high risk pregnancies come to us. All the high risk complications from neighboring towns and villages come to us. That's why the C-section rate is around 35 to 38%. But when I compare it with other tertiary care hospitals, they have already crossed 50, 55, and 60. So when I compare with other tertiary care hospitals, the rate of C-section at my hospital and the type of cases we are getting, I'm quite happy. But at the same time, we are following Robson's classification and trying to find out in which category what sections are being done. So I strongly believe that there is always a scope for improvement, even in C sections. It depends. It's a teaching hospital. Many times the junior faculty who is on call, they do not want to take any risk and they take the women for C-section. Vaginal birth following C-section is also being practiced depending upon the case criteria or clinical situations. So it's not that once a section, always a section. That we are not doing. We are giving a trial for vaginal delivery in previous sections. So with these certain protocols, we are able to keep the C-section rate around 35% for a tertiary care hospital.
And I think just to share, because I know from the other ICI facilities, I think it's true at almost every facility globally right now that we're seeing C-sections increasing, regardless of the type of facility. I know
This C-section on demand, Michelle, C-section on demand is also increasing.
I know.
Many times there is a sort of a fear of labor pains, tocophobia. And that's why I tried to give a lot of importance to pain relief in labor, whether pharmacological or non-pharmacological methods. If we introduce these methods and sensitize these women during antenatal period, all that demand for C-section, for pain during labor would definitely come down. We need to give them all the options possible. They want it, but the main thing is fear of labor pains. And that's why they are asking for elective C-section. That is controllable.
Yeah. I think everyone is seeing the same, and I think that there's going to be a lot of movement across the hospitals that are working on this area with the patient education, but it's going to be a slow process because it is, in partnership with the community and with, the global trends. And Ray Davies has put a link for information about water birth into the chat, for those who are asking. Are there any other questions right now? Also, regarding the languages, I think we will try to do this same introduction to ICI in Spanish and in French in the coming months. But then we do also have some recorded videos in those languages that we will make available. If you need resources in a specific language, please email me and let me know. I don't think, we don't have recordings in every language. And I think that we do, we don't have a lot of, I don't see much option under the translation for the captions right now, but we can try to work on that as well. And Dr. Bangal, thank you so much, because there really are so many compliments, and it is quite a lot of work. And I think it's helpful to see the example of a large, busy hospital such as yours, where you're facing a lot of challenges, that this was doable, and that you've had positive feedback.
I do have those videos in alternate birthing positions, which are taken with all due precautions about the privacy and confidentiality and with the due consent of the women. So in any further sessions, they are all small, very brief 2.5 minutes videos in all the alternative birthing positions, live videos. So maybe around 20 minutes, we can show all the positions, maybe in subsequent session.
That would be
That is being practiced now as a routine at my place.
So there's also a question regarding the vaginal breech presentation. And I'm guessing the answer to this. So the question, I think, is are you attempting vaginal delivery for all breech presentation? I think that's
No, we do not, because breech presentation, there is a universal now acceptance that primigravida, first pregnancy with breech, we usually go for C-section. When she is a multigravida with all other criterias like birth of the baby, birth weight of the expected birth weight of the baby, type of breech presentation, any previous C-section. So depending on that, we decide whether she is to be kept for vaginal delivery or not. My general observation is that when women come in active labor, usually they, with breech presentation, they do deliver by vaginal route. And overall, the number of breaches are quite less, but because at many places these breaches are being delivered by C-section. So we are selective in choosing which is for vaginal route, which is for C-section.
Yeah. And I think, I think similar is true for most of the facilities that are doing vaginal breech delivery. It's very good that you have the skills, because I think also that is something that we're seeing at certain sites. There aren't a lot of providers trained in vaginal breech delivery. And Ray has again put the resources for Breech Without Borders into the chat for those who are interested in that. Are there any other questions? Or Ray, would you like to unmute and say anything?
Well, besides a huge thank you, I'm so impressed. And I did put a comment in there about involving the community, because you hear really what's happening about what mothers are saying from the community. And then when your community is involved, they can educate the women even before they're pregnant about all the wonderful options that you have and how women are treated so respectfully. And so I've been doing this work for a long time, and it just brings tears to my eyes to see this presentation. Thank you so much.
Thank you very much.
And I'm happy to open it up if anyone else would like to unmute and say anything about your experience where you're working, any questions or comments you have about anything before we start to draw to a close.
I have something to say, just a line. These last 3 years, I have introduced or incorporated midwifery practices or principles of midwifery into obstetric practice. There is a lot of hesitation and sort of a resistance from obstetrician to take these good practices from midwifery. I do not know the reason for that, but my personal opinion is that we must take what is good from midwifery, incorporate it as an additional facility for our women, and that is definitely going to help us. I'm working with Japaigo these days with the midwifery practices, and with my initiative, they are also quite happy that some obstetrician is talking about midwifery and inclusion of midwifery principles into obstetric practice. So that is what I'm a strong believer that there are so many good midwifery practices. They must be incorporated into present so-called modern obstetric practice.
Thank you so much, Dr. Bengal. I feel like you said that very well. And I think it is one of the core goals that ICI has, is to really get all of the providers to be taking, the good from all areas of practice and not having these defined borders that are limiting us and limiting collaboration. Well, I think that's a great point to end on. I want to say a huge thank you to all of you for joining today. I want to thank Dr. Bangal. Again, I want to thank Ray Davies representing the International Mother Baby Childbirth Organization, one of the leads for ICI. I just wanted to see if there's anything else here in the chat, but I think we've covered the questions. So we do have the slides ready, so those will go out quickly, and then I will also follow up with the about the French resources. So thank you so much. If anyone, actually, I should have asked this earlier. Is anyone actually at a facility that is considering joining, that you might want some follow-up to discuss any other details about the application? If you, before we go, put it in the chat if you are at a facility, or if you know of a facility that might be interested, please go ahead and make a note in the chat before you go. Oh, thank you, Inez, for being here. We had a cohort come in early in the year, at the start of the year. If we have a number of facilities that are interested in coming in again, we would set up a second cohort for the coming months. Feel free, if you don't reach out now, to send an email. If you do, I know we've given the link to the application, but if you do submit an application, please also send me an email, because we don't get an automatic notification. So if anyone is applying, please also message me at mtherian@icichildbirth.org, so that we pay attention and turn around the response to your application quickly. Okay. Thank you so much. Oh, great, Judith. Okay, thank you. And I will also stick around for a minute if anyone has any sort of very specific questions. But otherwise, I will end the recording, and I hope to see you all. So our next session will not be our next webinar will be in 3 weeks. We will be hearing from Inez Carey who is working as oh my goodness, I'm sorry, people are still joining, who is completing her fellowship at La Florida Hospital in Santiago, Chile. She has done a wonderful piece of qualitative research that's still ongoing. And we're really looking forward to hearing about those experiences of the patients in Chile, as well as experiences of some of the healthcare providers from her research. So please, that will be on July 3rd. Wednesday, July 3rd is our next scheduled session. And we will email you so that you have all of those details. All right. Have a wonderful day, everyone. Oh, sorry.
I said thank you.
Thank you. Sorry to cut you off, Sarah.
Sorry.